So in blood, what have you all finished so far? You guys planning to settle down or you still want to continue? I can always leave the class. ಇಲ್ಲಿದೆಲ್ಲ ಲೈಟ್ ಹೋಗಿದೆ ಹಾಂ ಅದೊಂದು ಸಂತೋಷಿಗೆ ಹೇಳಾಯ್ತು. What have you all finished in blood so far? Huh? It's a very good beginning you all are having. So what have you finished in blood so far? The jaundice, okay. So have you finished RBCs? Huh? Yes. What did you do in RBCs? What did you study in RBCs? Huh? Glue is put there. There's glue on your chair. Sure. Huh? What do you know about RBCs? It stores oxygen. Why? It stores hemoglobin. Why does it want to store oxygen? That's what he said. Why does it store oxygen? ಅದು full ಬರುದಿಲ್ಲ. Why does it store oxygen? Why does it have oxygen? Why does it bind to oxygen? To supply oxygen to other parts of the body. That's all? That's all? It only binds to oxygen? That's hemoglobin. Yeah. Come on, I'm asking you, what does it bind to? Other than oxygen, what does it bind to? Sit. Carbon dioxide, yes. Where does the carbon dioxide come from? You need oxygen to get up, huh? Stand up. Takes it from the tissues. Why? Why? Why does it take it from the tissues? No, why does it take it from the tissues? Why? Why carbon dioxide has to be expelled from the body? It's not needed. Pardon? Why do you require to remove carbon dioxide from your body? Anyone? You, last row, girl, come in. Get your book and come. Why do you want to remove carbon dioxide from your body? What will happen if it is still there? Huh? It won't bind to oxygen. Huh? Okay, there's a change in the pH. What else? What happens if carbon dioxide accumulates in your body? Come on. Huh? okay, forget about removing the place of oxygen. What happens if, my question is, if carbon dioxide accumulates in your body, what happens? H drops, pH drops. So what happens? Sit down. So what? So what if your pH drops? Huh? Metabolic? Metabolic pathways are disturbed. Oh, okay. Anything else? You leave oxygen out of it, yeah. I'm asking you what happens if carbon dioxide accumulates? If there's a whole lot of crap in this room, what will happen? Huh? It causes toxicity. Simple. So carbon dioxide is not required for your body at all. Accumulation of carbon dioxide will always cause acidosis, metabolic acidosis, which is toxic to your body. The moment it goes beyond a certain limit, you are more likely to conk off. You understood? So forget about it taking the place of oxygen. It is already taking, no. It has released oxygen, hemoglobin has released oxygen, taken carbon dioxide and brought it. So it has to release carbon dioxide somewhere. If it doesn't release, what happens is my question. So that is the role of, next to you, yeah, next to you, not you, you sit. You're happy to see me? Huh? You're smiling away. At least someone is happy. I'm too happy to see you. Sit down. Let's talk about WBCs now. So RBCs, what you have basically understood is, RBC is a cell, one of your cell, which actually helps to carry oxygen. It mainly helps to carry oxygen. That is the main role of RBC. But let's talk about, let's talk about your white blood cells, or what you can also call as leukocytes. Okay? Now, the thing is, what can you tell me now? What do you know about the differences between leukocytes and erythrocytes? What are the basic differences you can think of between leukocytes and erythrocytes? That's not going to work. So one by one, if you can just point out one difference after another, will be a great help for me. Anyone? Yes? Good. Next. Yeah. Wonderful. Next. Yes, next. You run out of differences? What are the other differences? Come on. You just now mentioned. Pardon? What's the lifespan of an RBC? What's the lifespan of an WBC? Huh? 4 days. I would 7 to 4 days. It's around 1 to 2 days. Okay. Next. Any other difference? Come on. We discussed it so much. Difference between WBC and RBC based on function, functional difference. Stand up. One of you have to stand up. Yes. Basically transport of gases. WBC? Yes. It's a different structure in our body. One of the most different structure in our body. Good. All right. So what we are going to do today is, we are going to talk about Just give me a minute, please. Okay, you're going to talk about these particular parameters of WBC or leukocytes. Start with a brief introduction, and hopefully I'll finish off leukopoiesis and classification of WBCs. All right. So what you're going to learn at the end of this particular class, you're going to be able to know what is leukopoiesis, what do you understand by the term leukopoiesis, what are the different stages of leukopoiesis. Just like erythropoiesis, there are different stages. But in leukopoiesis, we don't focus too much on factors. All right, leukopoiesis, we don't focus too much on factors, but erythropoiesis, we do focus on factors, which is a major part of the long essay question that comes over there. All right. All right. Now coming to what do you mean, how was WBC first synthesized or first discovered? The two of them actually simultaneously discovered the existence of leukocytes or WBCs in the bloodstream. One is a French professor of medicine called Gabriel, and another one is an English practitioner called as Addison. So they are the first ones who actually discovered leukocytes in the bloodstream and gave importance to these particular cells which are there. Now when you classify WBCs, you can classify WBCs broadly into granulocytes and agranulocytes. Okay? Granulocytes, as the term indicates, it contains granules. It contains granules in the cytoplasm, whereas agranulocytes, obviously, no granules in the cytoplasm. So granulocytes were first classified into three main types. One is neutrophil, eosinophil, and basophil. And agranulocytes were then divided into two. One is monocytes and the other one is lymphocytes. So broad classification, when you look at it, you have granulocytes and agranulocytes. Always when someone asks you which are the different WBCs, you go via the route of classification. All right? You first classify the WBCs, and after classification you mention which are the granulocytes and which are the agranulocytes. Now, structurally when you look at it, this is how most of the cells, granulocytes, look like. You have the neutrophil, the eosinophil, and basophil, and then you have monocytes and lymphocytes. I will come back to that particular aspect in detail later on. This is just to give you a picture. Now what you have studied in erythropoiesis can be also termed as hemopoiesis. These are all having overlapping features. They come from a common cell. All of them arise from a common cell, a pluripotent hemopoietic stem cell. Now you have to understand that this pluripotent hemopoietic stem cell has the capacity and the ability to transform itself either into an RBC or into a neutrophil or eosinophil or a platelet or a monocyte. All right? It has the ability to do that. Now, how does it do that? It is based on the situation in your body. If at that particular moment your body is going through a sharp fall in RBCs, then these hemopoietic stem cells are regulated in such a way that they produce only more of RBCs. But if the situation is you have a very strong acute infection taking place, then it will be the WBCs, in particularly the neutrophil, that first goes and gets produced or increased in number. Now, this pluripotent hemopoietic stem cell then finally goes and gets connected to the myeloid stem cells, or it gets formed into a myeloid stem cell. Now, what do you understand by the term myeloid? What do you understand by the term myeloid? You have gone through this myeloid stage of RBC synthesis. No? RBCs are synthesized in 3 stages: the embryonic stage, the hepatic stage, and the myeloid stage. What do you understand by the term myeloid? Pertains to what? Bone marrow. Yes, it pertains to the bone marrow. So, myeloid stem cells are those stem cells which finally gives rise to those blood cells which arise from the bone marrow. All right. Now, which one does not arise from the bone marrow? It is the lymphocyte. So, that is why it is specified that myeloid stem cells are nothing but progenitor cells of either RBCs or the granulocytes and monocytes, all right, but not the progenitor cell for lymphocyte. It is not a parent cell for the lymphocytes. Okay. Now, coming to leukopoiesis proper, what do you understand by the term leukopoiesis? It is not only the development, the different stages, it is also the maturation of WBCs, all right. As I said earlier, they arise from a pluripotent stem cell. It is a hemopoietic stem cell which has the capability of developing to any of the myeloid stem cells. This in turn, it forms what is called as colony forming units, which are considered to be the progenitor cells, all right. These are the colony forming units which are called as the progenitor cells. So, colony forming units, I will come back to that again. Now, removing the equation of RBCs from here, as I said, hemocytoblast, a pluripotent hemopoietic stem cell which gets converted to a myeloid stem cell, and this is the one which gets converted to a committed cell. Now, once your body decides that it wants more of neutrophils, then this cell, myeloid stem cell, next gets converted to a committed cell. That means it is now committed to form either a neutrophil or an eosinophil if it thinks it requires eosinophils, or a basophil or a monocyte. So, the moment the myeloid stem cell gets converted to a particular myeloblast, it is committed to form a particular line of synthesis. You understood? So, once it forms a committed cell, it cannot change, jump over from here and finally decide to form an eosinophil or a monocyte, all right. So, let us talk about granulopoiesis, that is the synthesis of the granulocytes. So, when you look at granulopoiesis, of course, same thing, it forms from a hemocytoblast which gets converted to a myeloid stem cell, since these are cells present in the bone marrow. Now, this myeloid stem cell gets converted to what is called as a myeloblast. Okay, this is the first committed cell which is present in the process of granulopoiesis. All right. So, the first committed cell is called as a myeloblast. Now, please remember the fact that once it forms a myeloblast, it can either form a neutrophil, an eosinophil, or a basophil, depending on the need of the R. Now, myeloblast is a little larger cell than the final end product. So, it is around 18 microns, 14 to 18 microns. It is a little larger cell. It is most of the time oval in shape. It has got a nucleus which can be slightly indented, okay? Not a perfectly round nucleus, but a nucleus which is indented. It also contains nucleoli, all right? It also contains nucleoli, and the cytoplasm, as you can see, is basophilic over here. So, that means it is bluish in color, but no granules. At this particular stage, there are no granules in the cytoplasm. Now, whenever you come across a term which or a word which ends with a suffix of blast, what does that mean? Huh? Huh? Okay, helps in the formation of others. Anything else? Yes, my dear girl. What do you understand by the term blast in relation to this particular? Anyone? Sit. What do you understand by blast? It's a young cell. Very good. Whenever you come across a word which ends with blast, that means it is an immature cell. It's a very immature cell. It's not a functional cell. It's a non-functional immature cell which has to develop further. So, a myeloblast then gets converted into what is called as a promyelocyte. All right. So, it divides, it multiplies, and it forms what is called as a promyelocyte. Now, once you get the word myelocyte, that means a word that ends with cyte, that means the maturation process has already started. Okay. Now, promyelocyte again, now you will see the appearance of granules, bluish color. You use the word azurophil granules because it takes up whenever again fill, PHIL, when you use the word fill, what does that mean? Philia means? Philia means? Somebody said loving? Yeah, okay. Philia means yes, affinity. Phobia means? Yes, phobia means a fear. So, anything that is phobic, it goes away from you. Anything that is philic, it comes towards you or it is attracted towards. So, it has azurophilic granules. That means when you stain it, it takes up or it picks up the bluish, dark bluish color stain. So, this is where the cells appear slightly or the granules appear slightly bluish in color. Now this promyelocyte undergoes mitosis and severe multiplication. So, it forms what is called as a myelocyte. All right. Now, this myelocyte, as you can see now, very clear appearance of granules. Nucleus is still there. Nucleolus actually disappears, and then it forms what is called as a metamyelocyte. Now, from metamyelocyte onwards, the division stops, the multiplication stops. The cell becomes bluish in color with the cytoplasm, and granules are more in number. And remember, this is, I am now talking in terms of it's going to form a neutrophil, all right. Once it forms a metamyelocyte, it then forms what is called as a band form. Now, band form is where the nucleus becomes almost bilobed in shape, all right. You call it as a band form because the nucleus becomes almost bilobed in shape. All the granulocytes have nucleus which are either bilobed or multilobed. In case of neutrophil, it is ultimately a multilobed cell. So, it becomes bilobed, so you call it as a band form. No more division takes place, and this band form WBC then goes on to form a neutrophil, an eosinophil, or a basophil. As I am saying it again, it depends on the need of the hour. What does your body require at that particular moment? It gets converted to a granulocyte. It can be a neutrophil with multilobed nuclei, or it can be a eosinophil with bilobed nuclei, or a basophil with bilobed nuclei. Okay? So, to go through it once again very fast. Hemocytoblast gets converted to a myeloid stem cell. Now, once it forms a myeloid stem cell, it can either form an RBC or a granulocyte or a monocyte. But since I am talking about WBCs, you think that your body requires neutrophil. So, it forms a myeloblast which converts into a promyelocyte. These are all maturation phases, also phases of mitosis. Myelocyte, metamyelocyte, and then the mitosis stops. Then it starts only maturing. It forms a band form cell and then forms a mature WBC, neutrophil. All right. The whole process takes around 12 days for it to synthesize. What's the duration for RBCs? Takes around 7 days. Now, on the other hand, if you are looking at monocytes, it's the same story in the beginning. Hemocytoblast gets converted to a myeloid stem cell. Now, it is the myeloid stem cell which goes on to form what is called a precursor for a monocyte, which is called as a myelomonoblast. It forms what is called as a myelomonoblast. Now, this again is a huge cell. It's almost around 22 microns in size. It's a huge cell. The nucleus is, as you can see, very sharply indented, and cytoplasm is there, but no granules at all in the cytoplasm. Now, this monoblast gets divided to form what is called as a promonocyte, which is a precursor for the normal monocyte cell. So, it forms what is called as a promonocyte. The size may decrease now a little bit to around 20 microns, anything between 12 to 20 microns, but what is more evident is the fact that the nucleus becomes what is called as kidney-shaped nucleus or bean-shaped nucleus. All right. This is one of the characteristic identifying feature of a monocyte. When you, in your practicals, when you go on to do what is called as a differential leukocyte count, this is the most identifying feature of a monocyte. For you to recognize a monocyte is by the structure or the appearance of the nucleus. So, the nucleus is indented, so it gives an appearance of a bean shape or a kidney shaped structure, and it has chromatin in the nucleus. It has a network of chromatin in the nucleus. But coming to the cytoplasm, no granules at all in the cytoplasm, pale blue color cytoplasm. All right. So, when you do your experiment, when you do your practicals, you will find that you can identify a monocyte very easily, basically by the structure of the nucleus, all right, the shape of the nucleus. Now, another thing about monocyte which is slightly different from the rest of your blood cells is the fact that the monocyte does not stay in your circulation for long, all right. It goes and embeds itself or goes and parks itself in some tissues. And once it goes to these particular tissues, it gets converted into what is called as a macrophage. So, what do you understand by the term macrophage? Huh? What do you understand by the term macrophage? It's a cell, a large cell which is capable of, yes. It basically destroys most of the things which is not required by a body. Now, these monocytes, they go to specific areas in your body and gets converted to macrophages. For example, it goes to the skin and gets converted to what is called as the histiocytes. All right. So, in the skin, if there is any sort of debris, in the form of whatever the form may be, it may be in the form of bacteria, maybe in the form of dirt particles, it goes and eats up these debris. Or at the same time, it goes to the liver and gets converted to what is called as the Kupffer cells. You will be studying about this in detail more later. So, it forms what is called as the Kupffer cells. It can also go to your lungs, because your lungs is a rich source of all that nonsense that you take in every day. So, it goes to the lungs and gets converted to what is called as pulmonary alveolar macrophages, PMS. So, it gets converted to alveolar macrophages. Similarly, it goes to your brain also and gets converted to what is called as the microglia. All right. So, the monocyte is a traveling cell which goes to different parts of your body and gets converted to macrophages to bring about the destruction of whatever that is not required in your body. All right. So, they form what is called as tissue macrophages. Even though monocyte and neutrophil functionally they are almost very much similar in their actions, but monocytes are more powerful, they last much longer, and they have excellent amoeboid activity. That means it can move from one place to another. Even neutrophil has, almost all WBCs have this particular action of moving from one area to another area. So, that leaves the lymphocytes, which has nothing to do with your bone marrow. So, a hemocytoblast which is present, which is synthesized, forms what is called as a lymphoid stem cell. Now, how does it form a lymphoid stem cell? Simply by now this is the structure of a lymph node. Your body is covered with thousands of lymph nodes, all right. You have your submandibular lymph nodes, you have the submental lymph nodes, you have the auricular lymph nodes. So, there are so many lymph nodes, axillary lymph nodes. Now, most of the time you may have registered that whenever you have a very strong infection or a bad cold, so to say, you find that the lymph nodes get enlarged, they become a little sore, they become a little painful for you. That is when you actually remember them. But otherwise, they are totally out of sight and therefore totally out of. So, what happens is, in the lymph node, there is something called as a germinal cell. Now, this is the germinal center of a follicle, of a primary follicle. This is a lymph node. Now, the germinal center in the follicle is made up of cells which are called as reticulum cells. Okay? They are called as reticulum cells. Now, these reticulum cells in the germinal center are the ones that which get converted to a lymphoblast. Okay? So, the germinal cells which are there in a lymph node contains what are called as the reticulum cells. They contain what is called as reticulum cells. And it is these reticulum cells that gets converted to a lymphoblast. So, what do you understand? Where do the lymphocytes come from? From lymph nodes, from all lymphatic tissues of your body. There are other tissues which are lymphatic in nature. They also arise from other lymphatic tissues. Now, out of the lot, it is now recognized through recent studies. Conclusively, they have come to the what do you call it as conclusion that it is basically the thymus that synthesizes almost all of the lymphocytes in your body, even though the thymus becomes redundant when you grow older or as you become an adult. But it is the thymus that synthesizes 99% of the lymphocytes in your body and which is stored in different lymphatic tissues of your body. So, a lymphoblast then gets converted to what is called as a prolymphocyte. As you can see, in case of both lymphoblast and lymphocyte, the nucleus is round, but in some cases you can see the nucleus may be slightly indented also. Okay? Not necessarily it has to be a perfect round, but the nucleus, the cytoplasm is very clear cytoplasm. It is a bluish color clear cytoplasm. That means no granules whatsoever, but you get a pale blue color clear cytoplasm. So, how do you recognize a lymphocyte ultimately in your smear that you do is the fact that the nucleus is present in the center. It has got a large nucleus. So, what you forms is from a prolymphocyte it may form a large lymphocyte. Now, a large lymphocyte is a fully functional cell It's a fully functional lymphocyte, but there are some lymphocytes which are called as small lymphocyte. Now, these are just structurally two different cells, but functionally similar. So, you have in your smear something called as large lymphocytes and some cells which are called as small lymphocytes. But small lymphocytes are nothing but a more mature version, to put it very kindly, or to put it straight, it's an older version of a large lymphocyte. Understood? But it is not a senile cell, it is not a useless cell, but it is a fully functional active lymphocyte. Understood? Do you understand? So, you have a lymphoblast which gets converted to a prolymphocyte, which then gets converted to a mature lymphocyte. Now, these mature lymphocytes are present in your circulation either in the form of a large lymphocyte or in the form of a small lymphocyte. So, you can have a small lymphocyte whose nucleus almost covers the entire cell, just showing a sliver of cytoplasm towards the periphery, or you can have a large lymphocyte whose nucleus size is similar to the size of a small lymphocyte, only difference is the cytoplasm is more. All right? Clear blue cytoplasm in case of the large lymphocyte. Both are functional. Small lymphocyte is considered to be a more mature version of the large lymphocyte. And yes, the lymphocyte, as we go on later on, they get converted to what is called as plasma cells. That's an entire story by itself. We'll come to that later. As I said, now once the lymphocytes are synthesized, they can be stored in various lymphogenous organs and then pushed into the circulation through your lymphatic duct, through your thoracic duct, all right, or through your lymphatic vesicles. So, you can have the spleen, it can be stored in the spleen. This is the thymus where most of your lymphocytes are synthesized in the beginning. There are, in the bone marrow, there are areas of lymphocyte production or lymphogenous organs. In the intestine, there is something called as Peyer's patches, which are again lymphocytic in nature, and of course, the lymph nodes all over your body. So, these are the different lymphogenous organs which stores the lymphocyte and helps in the final synthesis or final release of lymphocytes into your circulation. So, when you look at the complete picture of just leukopoiesis, a pluripotent hemopoietic stem cell gives rise to what is called as a myeloid stem cell. At the same time, this pluripotent hemopoietic stem cell can also give rise to what is called as a lymphoid stem cell. Now, that is a different thing. Now, this myeloid stem cell, once it is produced, it can either form an RBC or a granulocyte or a monocyte. Now, since we are talking about leukopoiesis, let's stick to the facts here. So, a myeloid stem cell then gets converted to a myeloblast. Now, this myeloblast stage onwards, it is committed now to form either a neutrophil or a eosinophil or a basophil. As I said again, I am repeating the same thing. It depends on what your body needs at that particular situation. So, a myeloblast, if it forms, it is going in the line of neutrophils, it forms a neutrophilic promyelocyte. It forms, then gets converted to a myelocyte, then you have a metamyelocyte, then forms a band form, which becomes lobed over there, and then gets converted to a fully formed, fully mature neutrophil. Or it can go via the way of forming a eosinophil. The steps are the same. Myeloblast, eosinophilic promyelocyte, eosinophilic myelocyte, eosinophilic metamyelocyte, and then a band form of the eosinophil. Similarly with the basophil. All three are granulocytes, all have granules in their cytoplasm, all the nucleus are lobed. Only difference is neutrophil is multilobed, eosinophil and basophil are bilobed. All right. Now coming to a monocyte. A myeloid stem cell now decides it wants to produce a monocyte. It goes via the form of a promonoblast and then a promonocyte, and then it forms a monocyte. A lymphoid stem cell then gets converted to go through the same stages of a prolymphoblast, then it forms a lymphocyte. All right. Only thing is, remember that a lymphoid stem cell goes and stimulates what is called as the reticulum cells in the lymph nodes. Okay, the reticulum cells in the lymph nodes, and these reticulum cells are the ones which then go through the different stages to form a fully mature lymphocyte. But when you look at your blood smear, you may find two types of lymphocytes, a large lymphocyte and a small lymphocyte. I am not stressing too much on the size over here of each of the cells or any other further peculiarities or characteristic features, because we will be dealing with each cell in detail later on. All right. For now, you just remember what is leukopoiesis, where the hell does it take place, and how does it differentiate between a lymphocyte and the other what you call as granulocytes and monocytes. All right. That much if you remember, that is, I mean, that if you can understand that much, is great. Now coming to regulation, how is leukopoiesis regulated? You cannot have your body keeping on synthesizing WBC. There must be a sort of negative feedback control for this particular case. So whenever you have an increased number of useless granulocytes or senile granulocytes or granulocytes which are non-functional, or it can be monocytes, then what happens is it releases what is called as granulocyte stimulating, which is colony stimulating factors, or it can release monocyte colony stimulating factors, or it can release GM, which stands both for granulocyte and monocyte, or it also releases what is called as interleukins. Now interleukins is a type of cytokine which are proteins. Now these interleukins are the ones which help in synthesis of a number of blood cells in your body. They are cofactors which are required for synthesis. For now, if you just remember, these are proteins which are present in your body which help in further synthesis of any of the blood cells. Now these once these are released, it brings about stimulation of the bone marrow, which in turn brings about increased formation of either granulocytes or monocytes. Now once that is done, it goes and inhibits. Once the granulocyte and monocyte population increases in your blood, it then goes and inhibits the bone marrow to stop synthesizing more of the WBCs. You understood? It has to have a control somewhere. So this is a good example for, again, negative feedback mechanism, which is what is homeostasis all about. All right. Any doubts? Anyone? No doubts. So when you talk about normal WBC count, at the time of birth, your WBC count would be as high as 25,000 cells per cubic millimeter of blood. But as you grow older, that is up to the year of 1 year old, it gets down to around 16,000 cells. But in adults, it is anything between 4,000 to 11,000. It's fixed. There is no variation. This is one more difference between RBCs and WBCs. RBCs, there is a variation based on the gender. In WBCs, there is no variation whatsoever based on the gender. Okay? It's neutral, equality for all. So, at birth, 25,000. Once you are born, at the stage of up to 1 year, not more than that, goes up to 16,000. Then as you grow older, it settles down to a count between 4,000 to 11,000. Now this is a wide range actually, 4 to 11,000 is a wide range. So your WBC should be between this range. Anything just below 4 or anything just above 11 is detrimental. Okay? So the moment your WBC even touches 11, you say you are prone for leukocytosis. All right? It should not go. That means there is some sort of underlying infection in your body. The moment it touches 11,000 or 11.1, definitely there is some infection in your body. That's why you have such a wide range where WBC count is concerned. So what do you say is leukocytosis? When do you use the term leukocytosis? Whenever the WBC count goes above 11,000. Okay? So you can have physiological leukocytosis. As I said just now, age. When you are born, it's around 25. Once you grow up, it becomes around 11. Exercise. Whenever you do exercise, your WBC count increases. Mental stress. Now, emotional stress of any sort, anger, excitement, fear, increases the WBC count, and this is only because of the hormone adrenaline. When adrenaline is released, it stimulates your bone marrow to increase your neutrophil count. Pregnancy, especially towards the last term of pregnancy, and also during parturition, that is during childbirth, your WBC count is very high because to prevent any sort of infection. Postprandial, after food, you have a slight increase in WBC rather than when you compare before food. And whenever the temperature is low, when you're staying in low temperature areas, you tend to have a slightly higher count. When you take a demographic picture of people staying elsewhere, they have a consistently lower but within the range. Pathological, when do you get leukocytosis? Bacterial infections. Any bacterial infection will cause leukocytosis. Okay? Any sort of bacterial infection. You have appendicitis, you have tonsillitis, you have any word that ends with itis, you will have leukocytosis. Okay? So this, whenever you use a word which ends with itis, it means there is some sort of infection or an inflammation taking place over there, and that is a good example for leukocytosis. Burns, any sort of burns, whether it is minor burns or whether it is maybe second degree burns or third degree burns, your WBC count will go through the roof 100%. Post-operative, after a surgery, you will have an increased WBC count. That is normal. When they keep doing the blood investigations, they expect to see an increased WBC count. That means your body is fighting back. The moment you have any sort of surgery, it is a interference, it is an invasion of your body, and it is a drastic trauma to the body. So your body fights back by increasing the WBC count, which is your first thing to defend your body. Tuberculosis, again, tuberculosis, as you know, it's a bacterial infection, but again, mostly the neutrophil count increase. And any sort of glandular fever. Anything which affects your gland, whether it's your tonsil or any other gland in your body, will cause leukocytosis. Now this is conditions where are physiological leukocytosis and conditions for pathological leukocytosis. What do you call a decreased WBC count? You can call it as leukopenia, you can call it as leukocytopenia. You want to make it more attractive, anything less than 4,000. Physiological leukopenia is rare, it's not seen actually, but pathologically leukopenia by anything that causes what is called as non-pyogenic infections, that is infections which do not produce any sort of pus in your body. All right? Such infections are called as non-pyogenic. A classical example is typhoid. Now typhoid again is a bacterial infection. So it's the only one which is a little different from other bacterial infection which causes leukocytosis. So bacteria, typhi bacteria is a bacteria which actually causes decreased WBC count because it is a non-pyogenic infection. Viral infections, all viral infections, never mention viral infections for increase in WBC count, never, because all viral infections eats up or destroys your WBC, like influenza, mumps, HIV. Protozoal infections, anything parasitic infections. It can be malaria. These are the infections which actually decrease the WBC count. Dengue, starvation and malnutrition. Aplasia of the bone marrow is a condition where your bone marrow for some reason is not functioning properly. It becomes aplastic. That means it does not produce any cell. Forget about WBC, even RBCs or platelets won't be seen. So your bone marrow becomes aplastic, so your WBC count is affected. And finally, bone marrow depression. If you are exposed to too much of X-ray, radiation, chemotherapy, then it causes a leukopenia, okay, because it suppresses your bone marrow and your bone do not produce any WBCs. So this is leukocytopenia, where the WBC count decreases. Any doubts? Okay, call out attendance. 8, 9, 1 minute. You want to call out your attendance, let me give you a inside thing. The punch that you do is useless. At the end of the term, what is marked for your attendance or what is calculated is what I give. So you want attendance or sufficient attendance to write your university exam. Forget about attending the class. But you want attendance to write the university exam. You see that you call out your numbers loudly and clearly. I don't hear your number, you are absent. As simple as that. Want to give it a shot? Start from 20. 23, 24, 31, 9, 10. Why don't you focus instead of simply sitting and talking over there? Someone doesn't call 9, obviously you have to call 10. 1,
have gone through the cases and the slides? Silence. What are hemoglobinopathies? Okay, so my target will be the backbenchers. Silence. So what is the first case scenario? 15-year-old Indian girl presents with bilateral thigh and hip pain since a day. Severity of pain has been increasing. No relief with painkillers. No history of any recent trauma or excessive exercise, which could be the reasons for the pain in the thigh and the hip pain. She also complains of fatigue and burning during urination. Burning during urination is a symptom of urinary tract infection. So she has UTI, urinary tract infection. Come. Had similar episodes in the past, sometimes requiring hospitalization. Sometimes requiring hospitalization means that the condition was severe enough for the patient to be hospitalized. On examination, she is afebrile. What is afebrile? No temperature, no fever, with pale conjunctiva and mucosal membranes. Pale conjunctiva and mucosal membranes is nothing but pallor. Pallor is when the patient has anemia. So these are different words that you will come across later, but just for the sake, pale conjunctiva and mucous membrane means the patient is anemic. Okay. Rest of the examination was normal. WBC counts were elevated to 17,000 cells per cubic millimeter, hemoglobin 7.1 grams per deciliter, urine analysis revealed numerous bacteria. So with this history, you know that this girl has history of this sort of pain happening over and over again, which needs admission, and she gives a classical history of UTI, that's some kind of infection. Here in this case, use a urinary tract infection. So the diagnosis here is sickle cell anemia or sickle cell disease. Okay, let's see how it is, how we can confirm the diagnosis as sickle cell disease. Okay, now, so sickle cell disease and thalassemia both are a form of hemoglobinopathies. Hemoglobinopathies are group of disorders due to the mutations of the genes that codes for a alpha or the beta globin chains. Okay, as I said, there are 4 genes coding for alpha globin chains and 2 genes coding for beta globin chains. This is the basic. Now, under hemoglobinopathies, you have 3 different types of defects. One is the qualitative, which means there is a change in the sequence of amino acids, change in the primary structure. There should be a certain sequence of amino acids for certain proteins, but the sequence changes. So there is a qualitative defect. The quality of the primary structure, quality of the sequence of amino acids is different from that of the normal. So that is a qualitative change, and sickle cell anemia comes under this qualitative change. Okay. The next one is the quantitative, where if you see the chains, the sequence of amino acids will remain the same, but there is a production, there is a either absence or decreased production of certain chains. So it is a quantitative defect. Sickle cell, because there is a change in the sequence, it is the quality which is affected. Quantitative, because there is a amount of the concentration of alpha or the beta globulins, that is nothing but proteins which are affected. it is decrease in concentration. So, that is the quantity which is affected. The third one you will not be studying much, but just for the sake of completion, there is another type of defect where, as you know, when we are born, we will have lot of gamma globulins, alpha 2 and gamma 2. That is, we are born with fetal hemoglobin. Around 3 to 6 months of age, it slowly changes to the adult type of hemoglobin. So, when there is a problem with the switching over from the gamma chains to the beta chain because of some problem with the mutation or some problem with the genes, it is the hereditary persistence of fetal hemoglobin that you will not be studying, but for the types of defects you have to write this, but you will be learning only about the qualitative and the quantitative. Is this much clear? So, under hemoglobinopathies you have qualitative and quantitative. Qualitative because the sequence of amino acids, the quality is not there. The normal quality, that is a sequence of amino acids which in turn changes the primary structure of that particular protein will not be there. The second, quantitative, the amount of or the concentration of certain proteins or globin chains that has to be there is not there. So, let us see the first one, that is the sickle cell hemoglobin. Now, this is the most common form of abnormal hemoglobins that we come across. It is seen mostly in the African American tribes, Arabics, even in India in some tribal population, but the documentation in case of Indians are not, it is not very clear, but you have people suffering from the sickle cell disease even in India, and there are screening programs to find out if there is a trait or this problem or defect. The screening programs are there in Maharashtra, Gujarat, Odisha and Chhattisgarh, okay, because it is a genetic defect. So, screening is done for the population. And here, why is the name sickle? Because the RBCs, which are normally biconcave, will attain the shape of sickle, okay, sickle shape. So, production of sickle cell hemoglobin causes sickle cell anemia, and as I said, erythrocytes obtain a sickle shape at low oxygen concentration. So, what is the mechanism of sickling here? The abnormality here in sickle cell anemia is in the beta globin chains, okay. That is, there is a change in the, as I said, it is a qualitative defect. So, there is a change in the amino acid sequence. Normally, beta chain 6 position has to be the glutamic acid, but in this case it is replaced by valine. So, this is the whole basis of the sickling, okay. That is because of the different structure of glutamate or the properties of glutamate and valine. Now, there is another term if you see, heterozygous and homozygous. Heterozygous is an individual who receives the mutant gene from one parent, but a normal gene from another parent. So, because one is normal, it is a heterozygous, so the person will lead a normal life. So, he is called as a trait, okay. Homozygous individual is an individual who inherits a defective gene from both the parents. So, the person will have both the affected genes and he will be affected with the sickle cell disease. So, as I said, the difference is because of the single amino acid difference. So, this is one of the mutations where the structural variation, because of the mutation wherein just the beta position, that is a beta globin chain, 6th position changed from glutamic acid, that is the amino acid glutamic acid, to valine, okay. And this substitution of valine from glutamic acid results in something called as a sticky patch on the outer surface of the beta globin chain. So, if you take the hemoglobin, the sickle cell hemoglobin, whether it is oxygenated or deoxygenated, it will have a sticky patch, and this sticky patch are the ones which will stick to each other. So, before that you also have to know that this sticky patch is because of the change of glutamic acid to valine, okay. So, this sticky patch is not there in normal hemoglobin. be it oxygenated hemoglobin or deoxygenated hemoglobin. So, if you see this diagram, this is a normal hemoglobin, this is the sickle cell hemoglobin. So, what is the difference that you see? So, here oxyhemoglobin, this is the deoxyhemoglobin. If you see, there is a depression here or a groove which is called as the complementary site. So, actually even in normal hemoglobin you will have a complementary site which is exposed only when the hemoglobin is in the deoxygenated state. Okay? That is one point that you should understand. Only in the deoxygenated state you will have this complementary receptor site where the sticky patch will come and bind. If you see this sickle cell hemoglobin, it will have a sticky patch